Nice. All right, so now we're at part 3 of our cardiac rhythm interpretation course. We're going to be focusing on junctional rhythms for this one. All right, so the first one we're going to talk about is a premature junctional complex, a PJC. So if you remember from the previous lecture about atrial rhythms, we have premature atrial contractions, which are PACs, and premature junctional contractions, or complexes, are single premature impulses that are originating in the AV node rather than the SA node. So in this situation, the P wave is absent because the SA node isn't working, or it may be inverted because the electrical stimulation from the AV node travels back up the atrium and causes a reverse electrical stimuli, which is what makes the P wave invert. So what we'll see here is this is an example of a PJC. So as we work through this, we can say, okay, this is fairly regular. I feel like I've got a regular sinus rhythm. Oh, but this beat probably should have happened here and not here, so that seems weird, but everything else marches out well, and my P waves are good, my PR intervals are good, my QRS complex is nice and narrow, but this beat just doesn't really sit right. This is kind of a weird beat. So we know that it's premature because it happened sooner than we anticipated it happening when we marched it out. And when we look ahead, we can't really see a P wave. You know, you don't have this nice P wave like you had, or in the previous lecture when we had the PACs, you could see that there was some type of a P wave, even if it looked different from the rest. We don't have that here. So we know that it's a premature junctional complex, that it's happening from the junction because of the absent or inverted P wave. So here's another example. This is the premature junctional contraction, and you can see that's happening a little earlier than you would expect it to. The rest of them march out nicely. It should have happened here, but it happened early, premature, and there's no P wave in front of it. Right, so what causes this? There can be underlying heart disease, digoxin toxicity can potentially cause this. Some patients might complain of palpitations, feeling dizzy or tired, but most people are asymptomatic. You can monitor for signs and symptoms and try to identify whatever the underlying cause is, but most patients that have this don't require any additional treatment. All right, so what about a straight junctional rhythm? So this rhythm occurs when the AV node takes the primary role as the pacemaker. So atrial rhythm was all about the SA node. Now we're talking about junctional rhythms. It's all about the AV node. So the junctional rhythm can be seen on this EKG. And what happens is it's a failure of the SA node, or when the rate of the AV node surpasses that of the SA node. So let's take a look here. We look at our bottom 5 steps of EKG interpretation. So we typically see a regular rhythm, but now our rate, rather than 60 to 100, which was considered normal for the SA node, is 40 to 60, which is considered normal for the AV node. Our P wave will either be absent, which is what we see here, or inverted. PR interval, if it's present, if it's inverted and present, will still be within normal limits, and the QRS complex will still be within normal limits. So you can look at this and you can see right off the bat, if you looked really quickly, it'd be easy to think that this was just like a sinus Brady, right? And not look close enough to see that those P waves are gone. But without the P waves there, it's telling you, hey, this isn't coming from the SA node anymore. The junction's taken over and the AV node is eliciting these responses. So what causes this? Digoxin toxicity, MI, drug use, cardiovascular surgery that might have compromised the electrical pathways. Patients might, again, experience palpitations, fatigue, dyspnea, lightheadedness, or syncope. We would want to closely monitor our patients, especially those with cardiac disease or in older patients who have a low tolerance for decreased cardiac output. Because if you think about it, if they don't have that P wave, they don't have that atrial contracting, they're losing some of that atrial kick that we talked about in that last lecture. And what do we do for this? Well, we want to treat the underlying cause. And if the rate is too slow for perfusion, then we can consider atropine or epinephrine, or maybe transcutaneous pacing to help increase that rate. Well, now we can also have accelerated junctional rhythm. So accelerated junctional rhythm originates from the AV node at a rate greater than the traditional junctional intrinsic rate that we expect to see of about 40 to 60 beats a minute. So the rate for accelerated junctional is 60 to 100. So you're going to see as we look through here, everything else stays the same, but that rate increased. So the rhythm's still regular, rate increased to 60 to 100. P wave is still inverted or absent. PR interval if present still normal. QRS complex is still normal. But look at this. This is what's interesting. This even more so is easy to diagnose as sinus rhythm because of how quickly you can look at it and say, oh, nice narrow QRS complexes and it's a normal rate. It's probably fine, right? But it's not. It's actually accelerated junctional rhythm. And I like this example because you can actually see those inverted P waves in front of all of the QRS complexes. And I think that's more noticeable than the absent P waves. So what causes this? Digoxin toxicity. Is that starting to sound familiar? It seems like digoxin toxicity hits us a lot for these junctional rhythms. History of cardiac surgery, history of an MI, myocarditis, beta blockers, calcium channel blockers. Again, patients might experience palpitations, fatigue, dyspnea, or they might have no complaints at all. Still monitor closely in patients with cardiac disease or the elderly. And if you need to treat, then you can treat symptoms using ACLS algorithms. Most of the patients with this rhythm, though, aren't going to be symptomatic unless losing that atrial kick. So again, about that 20-30% of your cardiac output from losing that atrial contraction is too much of a loss for them to compensate. So some of our end-stage heart failure patients may actually be symptomatic from this. All right, so one step higher, we've got junctional, which is a rate of 40 to 60, no P waves or they're inverted. We've got accelerated junctional, which is a rate of 60 to 100, no P waves or they're inverted. Now we've got junctional tachycardia, which is a rate of greater than 100, but again, still no P waves or they may be inverted. And that's how we know that it's coming from the junction, because the P wave tells us that the SA node's working, right? So we know it's not coming from the SA node, so it can't be an atrial rhythm. And we're going to talk about ventricular rhythms in the next lecture, but we know that this isn't a ventricular rhythm because our QRS complex is nice and narrow. And like we said in our first video, when QRS complexes are wide, they tend to come from the ventricles, but when they're nice and narrow, they come from above the ventricles. So if it's not from above and it's not from below, it's got to be from the middle. So that's how we know it's junction. Right. So functional tach, again, it originates in the SA node with a heart rate of greater than 100. Everything else is still the same when it comes to junctional rhythms, usually a regular rate. Our regular rhythm, a rate about greater than 100 for junctional tach, P wave, absent or inverted, PR interval, QRS complex, they're normal. Again, I'm going to say it, cause dig toxicity and potentially MIs and others. Patient presentation, again, palpitations, fatigue, dyspnea, lightheadedness, syncope, close monitoring of these patients in patients with cardiac disease or the elderly. I think we can start to see that that's the pattern with junctional rhythms, right? We got to keep a close eye on those patients that could actually have a lot to lose from losing that atrial kick. And we're just going to treat the cause and use ACLS algorithms if the patient becomes symptomatic. All right, so that's it for junctional. We've got our PJC, so our premature junctional contractions, junctional rhythm, accelerated junctional, junctional tach. That's it. All right, so let's do some practice. Using this first one, we're going to go through the 5 steps. Are we regular or irregular? I think we're regular. It looks like I can march this out really nicely all the way across. Our rate is about 90. We do not have a P wave before QRS complexes. And so we can't have a PR interval. We don't have a P wave, but our QRS measurement is nice and narrow. So what do we have when we've got no P waves, right? And a rate of 90. So we know it's not coming from the SA node because we have no P waves. A rate of 90 is faster than the normal AV node likes to function, because that usually likes to function at 40 to 60. But it's not so fast that we've gotten into the tachycardia category. So we have accelerated junctional. This is an example of accelerated junctional. All right, how about this one? We're going to use our 5 steps. So are we regular or irregular? So if I march this out here, seems regular. Oh, this guy should have happened here. But let me just keep marching out. Yep, everybody else is still regular. So this guy came too early. All right, so I feel like I have a sinus rhythm underneath, but I don't know what this guy is because he came too early. Well, let me look at him. I don't see a P wave. So if I don't see a P wave, it's not coming from the atria, but it's a nice narrow complex. So it's not coming from the ventricles. So I must have a premature junctional contraction. All right, how about this guy? We've got a regular rhythm. Everybody marches out nicely. A rate of about 50. We do not have a P wave before our QRS complexes, so we cannot have a PR interval. And we have a nice narrow QRS complex so that we know that that's not originating from the ventricles. So what do we have when we've got a rhythm with no P waves? A rate of 50, so between that 40 and 60, which is the intrinsic rate of that AV node, we know that we're in a junctional rhythm. So this is a straight junctional rhythm. All right, so next up, wanted to go back to junctional, but we're not going back to junctional. The next video that's going to be coming out is the ventricular rhythms, so stay tuned for that one.